A very warm welcome to this satellite, the science of differentiated service delivery, where we are and where we're going. I'm Gentry Dord. I'm a clinical research fellow in primary care at the University of Oxford in the UK and an honorary associate scientist at Caprisa in South Africa. And co-chairing the session with me is Kombatenda Sikombe, who's research manager at the Centre for Infectious Disease Research in Zambia. So over to you, Komba. I think you're there in person.
Thanks, Gianchi. So let me introduce a few people, presenters to the group. Our first speaker will be Peter Ehrenkranz, the Deputy Director for HIV at the Bill and Melinda Gates Foundation. Unfortunately, Peter can't join us today in person, so he'll be joining virtually. Next will be Nathan Ford, Scientific Officer with the World Health Organization. Welcome, Nathan. And he'll present on where we are with the science of differentiated service delivery. Our third speaker is to my right, from ABT Associates in Mozambique, Julio Paca, and he'll be presenting on accelerating DSD, access to DSD for HIV treatment during COVID-19. Julia is a leader in sexual and reproductive health with 20 years of experience in this field. Our fourth speaker will be Kumbo Nyurenda, and she's from Partners in Hope in Malawi, and she'll be presenting with Risa Hoffman from UCLA, and she's going to be joining us virtually. So they'll present on integrating hypertension treatment and support into DSD for HIV treatment models. And then Nkomeleng, who works with Health Economics and Epidemiology Research Office and that's in South Africa. He'll be presenting on DSD for HIV treatment on healthcare workers, highlighting lessons learned from the ambient work in South Africa. And so he's a researcher with over 5 years experience in public health. Last but not the least is Anna Grimswood. Many of you know her, Senior Technical Advisor at IAS, and she'll be presenting on where we're going with the science of DSD. Over to you, Gianchi.
Brilliant. So I think we should have the run of show up on the screen for you. We're really looking forward to this, an exciting session. We'd really like to remind speakers, though, please keep strictly to time, because this will let us have more questions. So we'll have about 5 minutes for questions at the end. Please, to everyone who's joining online, you can submit your questions via the online platform, and you can also engage in this session via via social media. So thank you very much, and over to Peter for, I think, it's a pre-recorded talk. Thank you.
Good morning. My name is Peter Ehrenkranz. I'm recording this from Seattle, Washington, where I serve as the Deputy Director for HIV testing and treatment for the Bill and Melinda Gates Foundation. It's my pleasure to welcome you to this satellite session on the science of differentiated service delivery, where you will hear from a selection of leading stakeholders and researchers in this space. All of these individuals are participants in the Global DSD Research Collaborative. The collaborative was established in 2020 by IAS, the International AIDS Society, with the intention of creating a virtual space where implementation science experts and stakeholders could work collectively on improving access to and quality of HIV service delivery by sharing recently published papers and research in progress. The group also discusses potential research gaps and seeks to define which questions can be assessed through analysis of existing datasets and which questions require new studies and funding. The theory of action is that by convening the people currently conducting research on DSD for HIV, opportunities for collaboration can be realized, and timely sharing of ideas can translate into accelerated updates to guidelines, both nationally and globally. In addition, there's an emphasis on growing the field by actively including junior researchers from the countries hardest hit by HIV and supporting their work. It is basically a virtual, international, work in progress session where ideas are pitched, early data is shared, and teasers about upcoming conference presentations or publications are presented. Supportive comments, questions, and suggestions are on offer from senior and junior researchers throughout the field. Overall, each session is a well-facilitated, rapid-paced, and inspiring event, as I'm sure this will be too. Today, we will hear a summary of the state of the evidence for DSD and HIV treatment, including evidence gaps and key science highlights from the pre-conference DSD for HIV in 2022. This will be followed by presentations from outstanding researchers describing various ways to answer different, really critical questions, such as expanding access to DSD during COVID-19, integrating HIV and non-communicable disease treatment, and the impact of DSD for HIV treatment on healthcare workers. Finally, we will hear about aspirations for the future of the research space around HIV service delivery and have a brief discussion. Thanks for your attention. I look forward to catching up with each of you in person soon.
Okay, thank you for the welcome and overview, Peter. Nathan, we shall get started with you on the science of differentiated service delivery and where we are. Thanks.
Good morning, everyone, and thanks to the organisers for giving me the opportunity to present, and I'll try to be brief so that we have good time for discussion. So I've been asked to present on the science of service DSD, where are we? And I guess what my presentation actually serves to try and highlight is not where we are, but where we want to go and where the gaps are. I have no relevant disclosures and conflicts of interest. So this slide and the next slide is briefly to summarise where we are at WHO and where we've come from with respect to global recommendations for service delivery. So in 2016, we put forward a whole chapter in the consolidated HIV guidelines, which give a number of recommendations to countries globally. They're meant to have global relevance. And I'll go on to the details of how we formulate these recommendations in a moment. And they had they went to different sections across the cascade of care, so linkage from testing to enrolment, retention, adherence, frequency of visits, task shifting, decentralization, integration, and adult-friendly health services. And then in 2020-2021, we had a process to update the gaps in the consolidated HIV guidelines, where we put forward a focus guideline on service delivery in early 2021, and then 3 months later, this was integrated into the consolidated HIV guidelines, which were released in July. And the areas that were touched upon in this updated service delivery chapter were again linkage from testing to treatment and prevention, rapid ART initiation, out of facility ART initiation, adherence and retention in care, tracing and return to care, task sharing and decentralization, frequency of visits, differentiated service delivery, service integration, and provider attitudes. Some of this was an update of what we'd already said in 2016, like the frequency of clinic visits. We had new experience in implementation. We had additional evidence from research, implementation science research studies. So we looked at revisiting that recommendation to see what we could update given the new evidence. And some of these were brand new recommendations touching on areas that where there were not previously any WHO recommendations, like tracing and return to care, and the provider attitudes good practice statement. So, drawing on the guideline development process at WHO, one of the opportunities of developing guidance and formulating new recommendations is to also identify key areas where there are evidence gaps and where we need research to be able to inform us to do a better job next time we come together to produce the updating of the global guidelines. So, for example, the 2021 guidelines that we developed had 32 experts from 18 countries, and then a range of other experts for the external peer review process. And we drew upon 12 systematic reviews that were commissioned to summarize the latest evidence across the domains I summarized. And then we had additional reviews on values and preferences, values and preferences of both the beneficiaries of the recommendations and those providing the interventions, so the health service workers. Values and preferences, feasibility. What do we know about the feasibility of implementing these potential new recommendations in different areas, and cost effectiveness and equity. All of these domains are additionally important, as well as safety and efficacy of a given recommendation, in order for WHO to be able to formulate a brand new recommendation. And so the range of expertise that comes from, as I say, 18 different countries, the update of the systematic review evidence that is there to help inform the formulation of a recommendation, and these other evidence to decision domains, values and preferences, feasibility and cost, all together allow us to have a good picture of what we know and what we need to know. So as well as the guideline development process allowing WHO to formulate new recommendations, it also allows us to identify those key gaps where we need new evidence for the next time we come together and produce guidance. And the rest of this presentation is aimed at very briefly summarising what we recommended and what we were unable to recommend and where we therefore want new evidence. So these were the new recommendations that were put forward. ART initiation may be offered outside of the health facility. The clinic visits and the drug dispensing recommendations were updated with a move towards, shall we say, a more liberal recommendation. So 3 to 6 months was already there in the previous guidelines, but what we have in the new guidelines is a signal of preference to 6 monthly intervals where this is feasible in a given healthcare setting. Tracing and support for people who have disengaged, sexual and reproductive health services to be integrated in HIV services, a second integration recommendation on diabetes and hypertension care, psychosocial interventions for adolescents and young people, and task sharing of diagnostic specimen collection. Within WHO guideline processes, strong recommendations are those recommendations for which there's sufficient evidence, both in terms of safety efficacy, but also the other domains, feasibility, acceptability, and cost. A strong recommendation is one that WHO recommends should be implemented in all settings around the world. And a conditional recommendation is one that can be implemented in many settings, but there are other settings for which there are concerns, whether it's based on the safety and efficacy or the other evidence to decision domains. So when you look for research gaps, by looking at WHO guidelines, it's those areas where there's conditional support for a recommendation that suggests we need more evidence to be able to promote this recommendation from conditional status to strong status. In other words, it recommended in many settings to being recommended in all settings. The evidence gaps that were highlighted through this guideline development process are all summarized in a collection of articles that are published in PLOS Medicine, and one of those articles is, as highlighted here, Future Directions for HIV Service Delivery Research, and it puts forward all of the questions that were formulated through the guideline development process and for which we as WHO are hoping that the research community will be able to deliver new evidence when we next sit down to produce an update of the guidelines. And I'm not going to line list all of the research gaps that you can find by reading the article, but I'll give you an indication of some of the types of questions that came out of the guideline development process. So, for example, when it comes to implementing ART outside of the health facility, we have good evidence from randomized trials that this provides good outcomes, but it's only a conditional recommendation because we still have questions with regard to client preferences, evaluation of tools for supporting initiation, and what staffing requirements are needed there. And so for all of the other recommendations, we have a list of research gaps that came out of the guideline development process. As I say, I don't have time to line list them here, but you will be able to find them in the article that's published in PLOS Medicine. So again, for the other recommendations, we have a list of key research questions that came out of the guideline process. So I'd like to stop there by acknowledging the large number of people, including some of you in the room, who supported the development of these guidelines, and I encourage those of you who are in a position to help answer some of these questions to take a look at the guidelines, take a look at the PLOS Medicine article, and we look forward to new evidence coming through to support us in the next round of guideline development at WHO. Thank you very much for your attention.
Thank you, Nathan. So our next speaker will be Julio Paca, who will share on expanding and accelerating access to DSD for HIV treatment during COVID-19. So just a quick one. Please do post your questions on the online platform for those who are online, and then for the crowd here, we'll have a chance to share questions at the end. Thanks.
Hello, everybody. Good morning. Oops. So first, I'd like to thank IS for the invitation, and also I'd like to thank APT for priming this USAID PEPFAR funded project. So, no relevant disclosures. ECHO is a multi-year and large USAID-supported project to deliver clinical care for people living with HIV in Mozambique. In this presentation, I will articulate our vision about the role of implementation, science and learning to help project address gaps through informed adaptation and innovation. ECHO's approach is to absorb learning from high-threshold studies, as some of Nathan presented, and bolsters the learnings with rapid cycle interventions, analysis that guide our implementation. This process allows us to take decisions based on what we are seeing, what the evidence that comes up from the field. And these help us to strengthening the quality of care in Mozambique at the same time as we implement our project. ECHO is responsible roughly to support 23% of the people living with HIV in the country at PEPFAR clinical supported sites, which is almost 350,000 patients. Our implementation science and learning strategy combines a vision where appraisal and evaluation is embedded in our regular programming, as I said. At any time that we have a challenge to face, we use our learning and adapting unit to inquiry our work. So this project is started like a few months before the COVID, okay? And it was good that we have incorporated this adaptive learning process because we had a lot of things to face in the first year of implementation. So I think that we did pretty well. If you look at the way that our cohort growth, like 63% over these 2.5 years, I think that we could face the challenge that COVID presented and overcome. And I represent 4 of the DSD models that we studied here in this presentation. Responding to COVID-19, the government of Mozambique decided to expand the access to multi-month medicine dispensing schemes to reduce the number of patient visits to the health facilities. The goal, of course, to reduce the instances of clients exposed themselves and offering a DSD model that could be more effective in terms of retention and virus suppression. As you can see in this slide, ECHO almost double the percentage of patients under 3-month drug dispensing, or 3MMD, over just 2 months from March to May 2020. And this was based on the expansion of the criteria to access 3MMD. The question that remained was whether we would find similar viral suppression rates among patients before and after the changes in terms of the criteria. To do that, ECHO conducted a retrospective study comparing viral suppression among patients that had criteria for 3MMD prior to the COVID-19 pandemic with those who started 3MMD after. We followed both cohorts for 12 months and found that viral load suppression rates were absolutely similar in both cohorts at 91%. Among those who started 3MMD in the new criteria, retention was also similar to those before, 83 and 81%, respectively. Interesting, this new criteria allowed a larger group of males to access multi-month distribution in the provinces that ECHO supports. Therefore, we recommended, in close coordination with the local Minister of Health, to maintain this criteria even after the COVID-19 pandemic is over, as it generates the same level of protection to a larger contingent of patients and also contributes to reducing the volume and thus burden on the health system. Things that also Nathan addressed in his speech. To reduce interruptions in initial stages of treatment and improve treatment for patients with different needs, ECHO invested in this 6-month one-stop shop model, specifically in facilities that were underperforming. This includes a series of specific visits to allow more comprehensive care to patients at one facility, single facility stop. Some key indicators were studied to assess the effectiveness of this model, particularly in areas where ECHO was struggling to obtain more substantive results. VL, viral load coverage, has risen from 19 to 32% in these sites. 1 second. Consequences of smoking in the past, not now, not anymore. Nowadays, our viral load coverage is 71%. So there was also an increase in 90% points in virus suppression. TB preventive treatment registered better completion rates, rising from 33 to 66%. Interruption in treatment also dropped from 40% after 6-month treatment to less than 80%. ECHO has been working closely with the MOH and various facilities to expand these models to other localities. This next one it's a very important one for us. A strategic investment for ECHO was in the strategy to scale up community dispensing of medicines through health providers. This applies to those patients who missed drugs pickups at any point before interrupting treatment, and it aims to keep them enrolled in 3-month distribution. While this strategy is responsible for more than 50% of the total patients that ECHO supports nowadays, we wanted to learn about health providers' perceptions, and they were very positive. They mentioned things like the reduced burden of drug pickups at the facilities for the patients, reduced waiting times, monetary incentives for them also help them to do better their work and somehow. They also observed from the patient perspective that reduced waiting times and decreased transportation costs were impactful. From the initial 26 facilities, we are now offering this model in more than 110 facilities. So, in serving more than 45,000 patients, which represents a large contingent in our cohort. And interruption in treatment reduced to 2%. So the last one is the private pharmacy, the direct distribution through private pharmacies. It was introduced in mid-2021 by the Ministry of Health, and we decided to conduct a study to better understand how kind of effective this model is, because it's more expensive. And we found out that it's interesting, but it needs a lot of adjustments. The logistics is complicated. The patients, sometimes they get lost. The interruption in treatment grew to 23% in the sites that adopted. So we are now studying and trying to make a cost-effective analysis to see if it's a model to be expanded and where to be expanded. It's almost red. So despite our great progress in the first 2 95s, ECHO is facing some challenges in the viral load coverage. And I have to change. Oh no, it's this one, sorry. The model presents all of this model presents additional challenges in terms of the viral load coverage. And now we are trying to face it. What's good to hear about the task sharing to collect specimens. So offering different DSDs and adapt them into different realities clearly expand positive health outcomes to achieve the 395s, especially when we face changes in the realities and context. Our results on 3MMD, 6-month stop shop, or community distribution show the process of adoption adaptation must be informed by evidence. When we asked whether we should rely on RCTs or more rapid studies that orient implementation, I would say both. The research questions determines the investigation model and not the other way around. As an implementer, our role is mostly to invest based on feasibility, adaptability, and then make adjustments also and also checking the health economic metrics to better inform the intervention models that we adopt. Thank you very much for all of you.
Thank you, Julio, for that wonderful presentation. So our next speaker is Kumbo Nyirenda for Partners in Hope in Malawi, and joining her is Risa Hoffman. They'll be presenting on integrating hypertension treatment and support into DSD for HIV treatment models.
Okay, thank you very much for the opportunity to present today at this important IAS slide about hypertension and HIV treatment. I'm going to co-present with Dr. Hoffman, as Komba has mentioned, and I'll take you through the very first slides, and then the remaining slides Dr. Hoffman will take you through. So this is our conflict of interest statement. So as Nathan mentioned, in 2021, WHO made a conditional recommendation that diabetes and hypertension may be integrated with HIV services. The recommendation basically emphasizes on gains that can be achieved within health systems if we support integration of hypertension, diabetes, and HIV services. Currently, people living with HIV are already accessing treatment using some DSDs, mostly multi-month ART refills. As such, they have less clinic visits for ART, and so aligning the provision of NCD commodities with DSDs for HIV should be considered. Some specific elements are included in the recommendations within the 2021 guidelines on frequency of assessment for hypertension and diabetic patients. There's a suggestion that those who have their blood pressure under control be followed up every 3 to 6 months, and also that pharmacological treatment of hypertension be provided by non-physician professionals like nurses, pharmacists, as long as they have proper training. The conditional recommendation also suggests that community healthcare workers may assist the health with health education activities, delivery of medication, and BP measurement. So without integration for hypertension and HIV treatment services, there are no efficiencies for the client as well as the health system. This figure here shows the current state of integration for NCD refills with DSDs. And it is notable that very few countries have a policy around this issue. South Africa is an exception and is really doing well in terms of integration. The policy for DSDs includes HIV, TB, and NCDs, and clients receive care through the National Central Chronic Medicines Dispensing Program. Currently, around 13% of the clients accessing care through this program are receiving aligned refills for ART and NCD medication. In Malawi, 20% of the people living with HIV have hypertension, and care for hypertension is received in diverse settings, where others receive it at outpatient departments, others at specialized NCD clinics, and others receive it in integrated HIV NCD clinics, which are mostly also centers of excellence. In our formative studies that we conducted at an ART NCD facility in Lilongwe, and in a group of people with non-hypertension, 80% were uncontrolled, and most of these people had MMD 90 or 120 days, but were coming back every 30 to 60 days for hypertension refills. In a separate study of 200 people with ultrasound of the heart, 13% had thickening of the wall of the left side of the heart, and a third of these people had elevated blood pressure. These data suggest uncontrolled hypertension is common, and it has clinical consequences. So additional formative work from our group shows that people with HIV and hypertension have barriers to care, including cost and time, and integration can overcome these barriers if it includes multi-month dispensing and alignment. And by alignment, we mean that the same amount of medication be given at the same time so that there are no extra visits for refills, especially hypertension, in between ART visits. As a result of our work, our hypothesis is that person-centered models may be associated with improved clinical outcomes. And therefore, we designed the Maconda study, which is looking at preferences for hypertension care in people living with and without HIV, with the goal of doing a discrete choice experiment with 1,000 people recruited from 14 facilities, and additionally asking them outside of the district choice experiment their stated preferences for hypertension care. And as part of the study, we also did a medical record review of a subset of participants with HIV to look at the frequency of hypertension and ART refills, to look at multi-month dispensing alignment and blood pressure control. We completed this activity. So the table you see shows the baseline characteristics of the participants in our study. Those with HIV had been on treatment for 10 years and 5 years on hypertension. Diabetes was more common in people without HIV. The chart review subset was generally similar to people with HIV and hypertension. We enrolled from 14 facilities, but 92% of the people came from the 3 fully integrated NCD clinics in Lilongwe, because we did not find people in other clinics. Of the people with HIV, 98% were on TLT and 91% were virally suppressed within the prior 2 years. I'll hand over to Dr. Hoffman for the rest of the slides. Dr. Hoffman.
Thank you. Next slide. So this slide shows stated preferences for hypertension care based on individuals' ranking of the attributes listed. You can see in orange, people with hypertension, and blue, people living with HIV and hypertension. Both groups were most likely to rank adequate stock of blood pressure medications in the facility as the most important attribute of care. Multi-month dispensing of hypertension medications was also very commonly ranked first for people with hypertension, while people with HIV and hypertension prioritized seeing the provider alone rather than in a group model, although MMD was also important for this group. Next slide. With regard to alignment of ART and hypertension among those with the detailed chart review data, 79% had complete alignment, meaning the same amount of ART and blood pressure medications were given at each visit. When we used a less strict definition of greater than 50% of visits, so 2 of 3 visits or 3 of 4 visits, for example, 90% of participants met the alignment definition, with the pie chart showing the most common aligned interval was 90 days, with 11% receiving 180 days, and 21% no predominant interval, so maybe 90 days, then 60 days, then 120 days, but always aligned. We looked at blood pressure control using the Malawi definition of less than 140/90, and that's the figure at the bottom. Overall, only 26% were controlled, and orange was those with control, blue those without control, and you can see that alignment does look better in those, control does look better in those with complete alignment, 28% versus 19%, although this was not statistically significant. Next slide. This bar chart shows the breakdown by blood pressure category, showing moderate and severe blood pressure elevations occurred in 37% of the population. And in this population, self-reported adherence to blood pressure medications was very high. 94% reported missing only 0 or 1 dose per week. Only 12% had a gap in blood pressure medication of more than 30 days based on prescribing data. And despite the uncontrolled blood pressure rates and high self-reported adherence, 89% of participants had no changes in their hypertension medication over the year. Next slide. So our study has several limitations. We were only able to enroll people living with HIV and hypertension at 3 centers of excellence in the Lilongwe, and this clearly may not be a representative population for Malawi or for the region. We tried and could not locate these individuals at our 11 other study sites. Our formal DC analysis is in process, so our report is of stated preferences only, and we look forward to sharing our DCE soon. Finally, it's unclear if participants were dispensed the entire amount of blood pressure medications as reported in medical records. We asked people if they had to come back for extra refills during the year, and less than 1% reported these visits, so we think that prescribed did correlate with amount dispensed in full quantity. In conclusion, participants in our study placed a high value on adequate stock and multi-month dispensing of blood pressure medication. People living with HIV and hypertension had high rates of viral suppression, but very low rates of blood pressure control, although a trend toward better control when their medications were completely aligned. So our integration in our study is a person-centered model if it includes multi-month dispensing and alignment. People wanted this and were very happy to have it, but it doesn't appear to be associated with a very high level of blood pressure control. So clearly further interventions are going to be needed to have those clinical outcomes that we would be looking for. Next slide. We'd like to thank our study participants and site staff. I'd like to thank the incredible team at Partners in Hope and colleagues at UCLA. Our funding is NIH Fogarty, and special thanks to IAS and Anna and Ami for helping with the presentation. Thank you.
Thank you, Risa and Kombo, for that wonderful presentation. We'll now call upon Nkomeleng Lekodeba, and Nkomeleng will present on the impact of DSD for HIV treatment on healthcare workers, and these will be lessons learned from the AMBIT trial. Thanks.
Thank you. Hi everyone, my name is Nkomeleng Lekodeba. I work for Hero in South Africa. Thank you so much for having me, and thanks to the International AIDS Society for their sponsorship. This morning I will talk to you about how the introduction of differentiated service delivery for HIV treatment affect healthcare workers' workload, job satisfaction, and their time use. I have no conflict of interest to declare. In addition to the benefit experienced by the healthcare lines, DSD models have been hypothesized to provide benefit to the healthcare providers and the healthcare system as a whole. This could be through reducing providers' workload by decongesting facilities, which could also result in enhanced job satisfaction. Under the AMBIT project, we have had the opportunity to evaluate the impact of DSD on HIV treatment, HIV treatment for providers' workload, job satisfaction, and their time use. We collected data from 45 healthcare facilities in Malawi, South Africa, and Zambia, largely during the second quarter of 2021. We conducted both face-to-face interviews with providers and observed them how they used their time through a time and motion component. I don't know about you, but the time and motion was new to me. What we did was to station data collectors outside the consultation rooms from the start of the working day to the knock of time. There they observed providers' time blocks classified by client time and non-client activities. So for client time, providers documented if whether it was, for client time, providers documented the type of patient seen and the type of services conducted during the visit. For non-client time, we documented if whether it was administrative tasks, meetings, or any other non-client related activities. We enrolled a total of 168 providers, which included both DSD and non-DSD clinical providers. As you can see by the last two rows of the table, a median years of experience was a maximum of 8 in South Africa and a minimum of 4 in Zambia. In all the countries, providers worked a median of 5 days on DSD HIV treatment delivery, but in Malawi and South Africa, providers were less likely to work on HIV treatment every day. Here we plotted a DSD coverage, and each bar on the figure represents a sentinel site. We defined DSD models as alternative service delivery, which differs from a conventional care by location, frequency of interaction with the healthcare system, the type of provider involved, and the type of services provided. The most common DSD models implemented in South Africa were the external pickup point, and in Malawi and Zambia, they implemented mostly multi-month dispensing. Our first set of questions was about whether the workload has changed since the introduction of DSD models. We measured workload in two ways. We asked questions to providers directly, and secondly, we observed them through a time and motion component. Here we present self-reported changes to workload from the survey, where the majority of providers reported that after DSD model implementation, they are seeing fewer lines each day, and they spend more time with each line, as shown by the figure on the left. Furthermore, as shown by the figure on the right, providers reported that DSD implementation freed up their time and made their job easier. This was not universal across all the countries, and it seems like in South Africa, providers were less likely to report these changes. In addition to workload, we asked healthcare providers a variety of questions about the impact of DSD on their job satisfaction. We thought that the most interesting group will be those who reported low job satisfaction, because they might benefit from interventions that are aimed at improving job satisfaction. There were 4 key areas associated with low job satisfaction. They were reporting that their job did not change, or their jobs became harder after the DSD model introduction, or being involved in 3 or more DSD models, and also experiencing pressure to enroll clients in DSD models. Our takeaway here is that though DSD models have a potential to improve the experience of healthcare providers, there are still some opportunities for improvement in the implementations of these models. Our last 2 slides on the result are related to the second way, which we measured providers' workload, the time and motion study. In all the 3 countries, we observed providers for a total of 166 working days from the start of the working day to the knock-off time. We are very grateful for the providers who allowed us to observe their days, and also the data collectors who worked really longer hours to capture this data. From these observed days, we divided facilities into groups. And based on DSD model uptake, we found that compared to facilities with low DSD model uptake, providers in facilities with high DSD model uptake worked slightly shorter days in Malawi and Zambia and longer days in South Africa. As shown by the figure on the left, they spent more time on direct line care in Malawi and Zambia, but less in South Africa. There was almost an hour of downtime in South Africa compared to other countries, which included the longer personal breaks and also a free time with no clients. The numbers above the bars represent the average number of clients seen per provider per day. These numbers show that the median DSD uptake did not meaningfully affect the average number of clients seen by provider per day in South Africa and Zambia. But there was a greater effect, as shown by a +10 more clients seen in Malawi, regardless of working shorter days and spending more time on direct client care. In the previous slide, we grouped facilities by DSD model uptake. Here we looked at time used per provider by clinic size. So, compared to facilities with low ART line volume, providers in facilities with high ART line volume worked shorter days in Malawi, longer days in Zambia, and almost the same duration in South Africa. They have spent more time on direct line care and had longer personal breaks and free time. Our takeaway for time use is that as DSD model uptake expand, reallocation of time, task shifting, and the integration of services can benefit the healthcare system as a whole. In conclusion, after assessing whether the implementation of DSD models benefited the healthcare system, we found that though most providers reported increased job satisfaction, a subset did not. So for those who reported low job satisfaction, were likely to have experienced no change in workload or pressure to enroll clients in DSD models. Furthermore, these providers reported seeing fewer clients and spending more time with each client, which could have had impact on their job satisfaction. However, when we observe how providers spend their time, we found that in facilities with high DSD uptake, providers spend more time on direct line care in Malawi and Zambia, but less in South Africa. This might be due to reallocation of providers' time on related activities. DSD models do have potential to free up providers' time and can also lead to increased benefits by increasing the economic of scale in the healthcare system. So in order to take advantage of this benefit, reallocation of providers' time should be considered in a more systematic way if facility performance is to be improved, and also make the effective use of downtime. While DSD models can have benefit on providers and the healthcare system, the expectations regarding the job satisfaction, job workload, and the time use should be managed accordingly. Okay, so the AMBIT project will be continuing for the second round. And for the AMBIT 2.0, we will be expanding the core activities of AMBIT 1.0. And the new activities will include DSD for HIV testing and its role in re-engagement. We will also be looking into building capacity to support skill set, increase our involvement in DSD research and local committees, and further translate research into policies. Thank you for listening, and many thanks to everyone who made this job possible.
Thank you, Nkomale. Okay. Last but not the least is Anna Grimsrud, and she'll be sharing on the science of differentiated service delivery, where we are and where we're going. So thanks. Please keep the questions coming online, and then we'll have a Q&A. And please do queue up next to the mics in the middle of the room. Thank you, Anna.
Well, I'm just really excited to be here today and to see all of you in the audience, to see how far WHO guidelines have come over the past few years, to hear about the research pipeline from the presenters. And really what I want to do just briefly here is try and motivate all of you and give a little bit of a call to action for more research and more areas where we're hoping to see this field grow and develop in the next few years. I have no relevant disclosures. So I'm going to start by talking about where we're going in terms of the content, and then I'm going to move a little bit into some of the methodology. So as has been stated, both in this session, but then also in the pre-conference, the DSD pre-conference, we really want to build on the resilience that we've seen during COVID-19. And I think Julio's presentation from Mozambique touched on that. So we know that we can safely provide earlier access. We can expand the populations that should have access to DSD. We need to work to ensure that we have strong community models, both community-based and community-led models. And we also know there are some exciting opportunities with the expansion of virtual support. And I think for those of us working in East and Southern Africa, we can also learn a lot from some of our Southeast Asian colleagues on how to do this. Also in this pre-conference, we talked a lot about how we can improve transitions. And what I mean by this is that there are moments when people are going to need to move between models as well as be up-referred or down-referred. And we want to make sure that we minimize the potential for them to interrupt treatment during these times. So we acknowledge that there are these moments of change in our life. They may be related to age, pregnancy status, clinical stability, and there might also be reasons why model preferences change, and so we want to support these transitions. There are these three types of transitions that we want to have some more research on and understand. So we are often hear about transitions from intense to less intense models, so this is when people are referred. We also know that we need to support people to transition between models because of the changes that I mentioned. And we also need to know and understand when we want to transition to more intense models. So these are just some areas that we would like to understand a little bit better, and we also know that we need to have more guidance for our implementers on how to support these moments of transition. Also, picking up on the theme of the conference, it's really time to re-engage in the HIV response, but we also know that they are re-engagement in care is a time when differentiation can support people. So we see from the WHO guidance that there is some recommendations on how to get people to return to care, but we need to think about what we're going to do when they do come back to support them being sustained back in care. And this is what I mean around re-engagement. Some data shared by Diana, who's in the audience from the pre-conference highlights how in most of our programs, people who are initiating treatment are not treatment naive, right? And so we need to think about how the health system can do better and not see this as a homogenous group, but potentially accelerate their access back to DSD models in order to support them. I also want to flag the exciting opportunities that we have with PrEP and differentiation. So this week, WHO not only launched their CAB guidance, but also launched a technical brief around differentiated and simplified PrEP. And so we can use these building blocks that we've been talking about in treatment and apply them to PrEP. So think about who can prescribe PrEP and who can distribute PrEP refills, where can this be done, how often does someone require clinical monitoring who's on PrEP, and what is that minimum package? We've seen a lot of the clinical package kind of fall away to support timely PrEP initiation, and we need to think about how things like self-testing can support people to have access to PrEP. As was mentioned by Risa and Kumbo, we also really want to make sure we're doing more around integration. I think this is a huge area of interest and something that we haven't really cracked, as was highlighted in terms of, while there was an improvement in terms of hypertension outcomes, they still weren't great. So we need to look at these 3 time points: when someone enters a DSD model, when they come and visit for a ART refill, and then when they come for their clinical consultation. What are we doing to support integration at these time points? And so we really hope that we can get some more research there around implementation science and what works and what is feasible around integration. Okay. Transitioning here a little bit to where are we going in terms of the approach, and this was also really nicely said by Giulio. It's not just RCTs, and Nathan also emphasized this. So there's a time and a place for a randomized control trial, and increasingly we hear and we see the value of implementation science. So to those of you who are designing studies, as was stated, it depends on the question, right? It's not always an RCT that's going to be best. And we know that there are ways in which our guidance and our policy can change from evidence generated from implementation science. So we need to do a better job of looking for this. And we hope that both through the collaborative and from the people in this room, we can start to think about how we can do these things together. We've also learned a little bit the hard way that we need to allow for choice within our study designs, right? If differentiated service delivery is about being person-centered and about someone having a discussion and working out what works best, it's not going to make sense to randomize them to the service delivery option that works for them. And we've seen people who have been enrolled historically in DSD RCTs just leave the model that they're in and go to another facility, right? So we need to be a little bit more clever in what sort of research designs we can put in place in order to allow that component to be evaluated in our research. And then some really exciting data that was shared from the AMBIT team is this idea of what is the impact beyond just viral suppression of these models. What's the impact for providers? What's the impact for the community? What's the impact at other levels? And so we also hope that we will have more research designed that looks at the overall impact on the health system as differentiated service delivery continues to scale up. You know, I'm not going to let you get away with hearing me speak without some kind of cheesy graphics and some cheesy takeaways. And I do just want to say that I think that we're going to have to go there together, right? And so I hope that we can look together at what questions the WHO needs answered and what is the research that's going to lead to those questions having sufficient evidence for more guidelines to be updated. Again, we need to be able to enable differentiation from prevention all the way through to re-engagement. we are really excited about the acceleration of multi-month dispensing, but we don't want to see 6-month dispensing and 6-month clinical visits become the new one-size-fits-all. It would just be a real disappointment if after all of this work, we ironically set ourselves up for one model again. And so we need to think about and listen to our recipients of care and our health systems for how we make sure we are still strengthening community models and providing psychosocial support for those who would benefit. So here, as always, is my pitch. Everyone does not need or want the same thing, and these needs change over time. So together we need to move towards equity, and that's when everyone can get what they need in order to improve the quality of their situation. Thanks very much, and we look forward to your questions.
Thank you. Yep, thank you. Everyone's queuing. Please do. Okay, we shall start with you. Thank you.
Good morning. My name is Yasmin. I have a question for Nathan, and actually it follows on nicely from Anna's presentation. So it's really important, the work that you're doing around the guidance for DSD. How are you incorporating long-acting therapeutics as we look to bringing them into resource-limited settings? And to Anna's point about making sure that we're working together, for those involved in the implementation science, what kind of guidance are you giving to what kind of evidence and the weight of evidence that would be really helpful to help build the differentiated aspect of long-acting therapeutics?
Excellent question. So we're laying the groundwork for the introduction of long-acting therapeutics. You might say we're not there yet, but we were in a discussion, a side meeting here a couple of days ago, where we recognized the irony of having moved towards a situation where clients are offered 3 to 6 monthly clinic visits, and the momentum has been towards trying to reduce the burden on beneficiaries in terms of how frequently they need to go to health services to pick up their treatment. The risk with the current long-actings is they're 2 monthly injectables. So are we, by thinking we're doing a service by providing a form of medication where it's easier to adhere, we're actually increasing the burden on clients by requiring them to go to injection sites every 2 months, whereas previously they were only going every 6 months. So these, as we're looking at the clinical evidence to support long-acting therapeutics, we need to, at the same time, be gathering evidence on values and preferences, in particular, on the side of the beneficiaries, to ensure that what we're proposing is what they want. So values and preferences is a key part of the evidence generation gap that we need to understand better. You also talked about implementation science research, and what we need to gather information on there is on the point of the administration of the long-acting. So injections are not the only way to administer long-acting therapeutics, but they're probably going to be what is coming, the way of administering long-actings in the next, let's say, 3 to 5 years. And so there, the key question is, where do people get those injections? Can it be self-administered? Can it be administered by lower-level health staff? In what types of facilities can those injections be provided? I spoke at length only about two areas. There are many other areas, and I'd be happy to speak with you more after this session.
Thank you, Nathan. Elliot?
Thanks. Elliot Reyes of CDC. You mentioned the 12-month clinical visit. I'm curious on the guidelines, how you go, I definitely agree that it should be in the research agenda, but could it not have also been as a conditional recommendation while you got more research that might strengthen it to a strong recommendation? Because certainly during COVID, a lot of countries were doing that anyways. My second question is on viral load. Using viral load, like in the ABT presentation, they said 91% viral load. I would actually consider 91% viral load to be a failure in a group that has high viral load suppression to begin with. So has there been discussion about what would be the ideal methodology to use viral load to sort of determine
Yeah, I'll take the first one, and you're quite right. We don't need clinical evidence before. What was surprising for me, actually, from the systematic review that led to the formulation of the latest recommendations, was that there wasn't a hands down moving from 3 months to 6 months as preferred. We actually ended up landing with a recommendation of 3 to 6 months, with a slight preference for 6 months. So to get to 12 months, be more on the values and preferences acceptability, but we didn't have enough in our hands a year ago, and you're quite right that we've got a lot of information to sift through.
And this one goes to Julio. So thank you for the positive results. How much of an impact? Oh, slightly. It's coming. Wow. How much of an impact did ECHO have on pregnant and breastfeeding?
Well, this is a very good point. Can you hear me? Yeah. So, among breastfeeding women and pregnant women, so we different CDC, even lower virus suppression among these groups. But definitely we are now launching a new efforts around the AP3 to try to overcome all of these challenges and creating more focused intervention for these specific groups, including a model that reinforces the whole health systems, because so pregnant women and their babies is much more about the capacity of the response in terms of the communities and the health systems rather than just one point of service delivery.
Okay, let's come back to the live question, Sydney. We're running out of time, so please do keep questions short. Thank you.
All right, this will be quick. Julio, also for you, can you just briefly explain what the difference is between what you called your one-stop shop for early treatment versus your regular service delivery?
Oh, definitely. So in this one-stop shop, so we have the same provider offering a series of services at the same point, and the patient doesn't go to different places to get the services. So they collect the drugs at the clinic, at the office of that particular health provider. They collect all of the samples that they need to viral load to all of the other clinical services that are being offered. So it's one single place where they do everything for 6 months.
Okay, please.
Thank you very much. My name is Elder Makul from Mozambique. I would like to listen from my colleague from South Africa. If you assessed also satisfaction of providers of one-stop model, because in this model, the provider must provide all services in the same cabinet, and if they also faced more time to conduct other activities. Thank you. Over.
Oh, one-stop shop models. We didn't have the one-stop models. Yeah.
Okay. Thank you.
Yes, thank you.
Okay, thank you. And lastly, just a question for you, Kumbo. Your name's like mine. So it's about the pharmacy distribution, I think, and how that's been working. I think it was yours, how clients adopted it. And really, I think the other thing was sort of like a question on the availability of drug stocks, to basically make alignment as well sustainable. Thoughts from you too?
Okay, yeah, so we did look at alignment and availability of drugs. We were doing this at one facility, which is sort of a center of excellence, and drug availability for HTN. That's why we mentioned about 30 to 60 days was okay, but beyond that, it was mostly for the ART, which was accessible for 90 to 120 days. Yeah.
Thank you. Colleagues, I'm really sorry. I won't be able to take more questions. So I'll pass on to Gianchi to close the session. Gianchi?
Thanks so much, Comber. Thank you, everybody, for a really fruitful session. It does feel like such a shame to end. It seems like there's so much more to be discussed. It's been great to hear about how the WHO develops guidelines, the research gaps identified, some of the DSD research that's been taking place from our three presenters, and then from Anna, the future directions that we need to go in improving or generating research to improve HIV service delivery for clients in the different contexts that we will work in. So thank you very much. I think there's a couple of housekeeping slides. Hopefully you're seeing those. If you have not registered already, and you can enroll in a free interactive online course on DSD for HIV treatment. The course contains 4 modules, and it's developed for stakeholders involved in the HIV response on the concept of DSD. On the next slide, hopefully you're seeing the DSD website, where you can learn more about DSD. It's got tools and evidence endorsed for use by national HIV programs and country implementers. And then lastly, I think it has been mentioned already, but there's an AIDS 2022 DSD roadmap where you can see all the latest science that's been featured in this conference. So thank you once again for participating, for the great discussion. Hopefully it will continue online and in the room there, and have a great day in the rest of the conference. Thank you, everyone.